Okay, so it's 3 p.m. and we are all set to begin with today's webinar. A very warm welcome to all our participants present here today. HRAI welcomes you all to the 2023 Dialogue Masterclass series on the topic Gestational Diabetes and Pregnancy. To know more about HRAI and its events, I would request all our participants to visit the link and details posted in the chat window. Request all the participants to kindly follow the webinar guidelines mentioned in the chat window. It would be great to have all the participants' feedback. We will be running a poll before the Q&A session. Request all participants to kindly give your feedback on the session. I now take the privilege to introduce our esteemed speaker for today, Dr. Nupur Gupta, Director, Obstetrics and Gynecology in Fortis Health. Dr. Nupur Gupta is the Director of Obstetrics and Gynecology at Fortis Memorial Research Institute, Gurgaon. She has been trained in one of the most prestigious research institutes of the country, All India Institute of Medical Science, New Delhi. Dr. Nupur combines passion with professionalism. She is an Indian gynecologist, medical writer, academician, born and brought up in the pink city of Rajasthan, Jaipur. More than 2 decades now in surgery and consultation, she believes in human to human touch with her patients. Her research and public health efforts have been focused on gynecological cancer screening, high risk pregnancy, managing PCOS, alternatives to hysterectomy, and medical abortion. Dr. Nupur Gupta is an honorary member of Indian College of Obstetrics and Gynecology and published over 200 articles in scientific journals, newspapers, contributed chapters in gynecology textbooks, and conducted numerous health workshops. She is also a recipient of many national and international awards for her publications as well as medical achievements. You can follow her on LinkedIn. The link for the same has been shared in the chat window. Without wasting much time, I now hand over the platform to Dr. Nupur. Over to you, ma'am.
So good afternoon, everyone, and thank you for introducing me. So I will try to make the topic interesting for all of you. So we are dealing with two big problems in India. One is hypertension and another thing is diabetes, which is rampant in our society. Whether we talk about genetics or environment or our lifestyle, we are all predisposed to develop these two conditions, diabetes and hypertension. So when we are talking about these conditions, they are also likely to affect pregnant women, and especially in India. So what is very important is that how we can prevent this diabetes during pregnancy, how can we prevent the harmful effects on pregnant women, on the new offspring, and how we can avoid getting them diabetes later on in their lives. So I will share a short presentation sharing that how it is affecting the pregnant woman, the newborn, and what we can do for its prevention. So this is the topic which has been chosen, and I have been asked to present this, which is gestational diabetes. So diabetes that develops during pregnancy, we call it as gestational diabetes. Gestation means pregnancy, and gestational diabetes is diabetes during pregnancy. Okay, just a minute. So talking about, there are two kinds of diabetes when we talk about pregnancy diabetes. One of them is diabetes that develops during pregnancy, and another is a pre-existing diabetes. So when we classify, we get two categories. One is pre-existing diabetes, another is pregnancy, which is itself causing diabetes to happen. And if you have heard of diabetes, we can call it either as type 1, where most of the individuals need insulin, type 1 diabetes, and type 2, where we can manage mostly by diet or by medical treatment. So today we are talking about diabetes in pregnancy, whether it was pre-existing or the lady developed this diabetes during pregnancy. So gestational diabetes is when glucose levels during pregnancy get altered, and they are of two types, just as we discussed. So what is the prevalence of this diabetes? It depends from nation to nation, from country to country, and also in races. So if you see the statistics, one of the highest incidence is around 10% that we see in our population or in our part of the world, which is the Southeast Asian countries. But it is a global health problem. In India also, we see many women getting affected and affecting the baby as well as mother in the long run. So almost 10% of women we used to see, but now it is increasing up to 20%. So that is the need for universal screening for all women who conceive during pregnancy. If we look at the population, whether it is more common in urban population, semi-urban or rural, the highest incidence is seen in the urban population because of our lifestyle, our eating habits, our environment, what we are eating, how we are leading our lifestyle, what kind of stress factors also play a very important role. So how do we test for glucose? This is a single test. It is called glucose challenge test or GCT, where we give you 75-gram glucose and after 2 hours, the blood sample is taken. If the value is more than 140 milligram, then we call the pregnant woman as to having gestational diabetes. So this is a test which we subject to every pregnant woman to screen for pregnancy-induced diabetes. This test is also advised for others as well. So what is recommended is universal screening, which I just spoke to all of you, that we need to screen every pregnant woman. Whether you have a history of diabetes, you don't have a history of diabetes in your family or in your close ones, but every pregnancy needs to be screened for diabetes. That is a must. So screening test, when should we do this screening test? When pregnancy happens. The first test is done during the first visit of the pregnant woman. And the second test is usually done between 24 to 28 weeks of pregnancy. So these are the two times when we screen for pregnancy-induced diabetes. Usually the gap between both of them should be at least 4 weeks to be able to diagnose it on time. So the test is similar, just what we discussed. You need to take 75-gram glucose. It has to be dissolved in water. And after 2 hours, you need to give the sample. But if you vomit within 30 minutes, we need to repeat the test next day. But if vomit happens after 30 minutes, then it is considered okay. So any value which is more than 140 milligram, no further testing is required. We say it is gestational diabetes. And now the management will be different. So it will be like pregnancy-induced diabetes. So we will manage as any other pregnant woman having pregnancy diabetes. So the cutoff is 140 milligram after 75 gram of oral glucose and sample is done after 2 hours. So why do you need to be aware of this? Is that any of your family members, any of your close friends, relatives, colleagues who have pregnancy need to be screened for pregnancy-induced diabetes. To create more awareness, every 10th March is also celebrated as Gestational Diabetes Awareness Day, that is called GDM. So why pregnancy itself is a diabetogenic stage? Means pregnancy will create or produce such hormones that women become more prone to diabetes during this time period. Why more glucose is being produced? So that there is uninterrupted supply to the baby. And there are certain hormones that are released during pregnancy which will alter the insulin sensitivity, which is responsible for glucose control in the body. So the insulin sensitivity reduces, and that is how they are more prone to diabetes. But at the same time, we should know what are the risk factors for this diabetes. So before pregnancy, if you are overweight, if you are obese, you have a sedentary lifestyle, or you have blood pressure, all these factors will increase your chance of pregnancy-induced diabetes. If you are suffering from PCOD, that is polycystic ovarian syndrome, if you have a family history of diabetes, or maybe if you develop hypertension during this pregnancy, then your risk for sugar is also high. And at the same time, if you plan pregnancy at a later stage, that is more than 35 years of age. So let us understand what is the pathophysiology, why it is happening. So it is happening because of insulin resistance, and the cells that produce insulin are called beta cells. So there is some dysfunction in the beta cells leading to insulin resistance and fall in insulin sensitivity, which will disturb the glucose metabolism in the body. And at various places in the body, this is happening. In the brain, in your fatty tissue, in your muscle, in your pancreas, in your liver, placenta. So all organs, there are different responses, different inflammatory cytokines that are being produced, and they will cause an environment which will make it more prone to have pregnancy-induced diabetes. But now what is happening? Because of this diabetes, what will happen? More sugar will go to the baby. That is called fetal hyperglycemia. And because of more sugar in the baby, more fluid will be produced. It is called polyhydramnios. And another reason why more glucose in the baby will reduce the production of steroid. And so the lungs will not develop, leading to respiratory distress syndrome. Another problem that they face is because of more glucose, what is happening? More insulin is produced in the baby, and more insulin will produce more fetal weight. So the baby will be heavier than a mother who has no diabetes. So it will also relate to problems during delivery. So what is happening is any mother who has pregnancy, who has diabetes before pregnancy, their babies are more prone to have congenital abnormalities. And now what is happening? There is too much of glucose in mother's body, so it is going to the baby. It will increase the oxygen demand, and more oxygen demand will lead to more metabolism, which is not good, and sometimes risk of miscarriage, or even baby sometimes dies in utero. After birth, what is happening is more chances of jaundice to the newborn. So what are the consequences? Consequences can be short term, can be long term. So we just discussed that why the baby now is overweight. So if mother's blood glucose control is not good, once we know that she has pregnancy diabetes, what problems can happen? There may be more risk of blood pressure. Baby will be larger than the normal size, will be overweight, and will lead to problems during delivery. Sometimes cesarean delivery is recommended. Maybe stay during hospital will be more. There are more chances of infection. For mother, in the long run, what problem can happen is that she might develop diabetes in near future. There might be metabolic problems, more risk of obesity, more risk of heart disease. So all these is a vicious circle. So that is why it is very important that we are able to prevent diabetes during pregnancy. What is important is that any woman who is obese, who is overweight, who has a family history of diabetes should see that they attain a normal BMI before planning for pregnancy, so we can avoid these complications. Like at one point of time, baby can be overweight, that is called macrosomia, but when we put dietary restriction on mother because of diabetes, then baby can be underweight also, leading to growth restriction. So during pregnancy, if sugar is not well controlled, then there can be other problems of metabolism. then ketoacidosis, and multiple other problems. So, how do we manage if pregnancy has been diagnosed to have diabetes? Number one thing is exercise. The more you are able to walk during pregnancy, better will be your sugar control. Second thing is that we need to start her on diabetic diet, which plays a very important role, and lot of things you need to control. Other than that, we can give some medications. Some medical treatment is also advisable, which we will decide depending on who needs what. Then blood sugar monitoring for baby, and then we also need to plan for delivery, that what is the best time to deliver. So if we talk about exercise, what is the minimum exercise they should be doing is at least 30 minutes of exercise daily is important, and it gives us a very good control. You need to see a dietitian who will give you the best medical nutritional treatment so that your nutrition needs are not compromised. We don't land up in baby having low birth weight or growth restriction, but at the same time, we are able to control sugars as well. So, what should a diabetic diet contain? Diabetic diet should have protein as 10 to 20%, carbohydrate, your fat, and now what will happen is that your meals will be spaced. So you will have 3 small meals and 3 big meals. And things that you need to avoid is sweet, potato, fried food, red meat, aerated drinks, and so on and so forth. So depending on your pre-pregnancy weight, you will be advised a kilocalorie diet, which will be per day. So if you are 60 kg prior to pregnancy, you will need 1800 kilocalorie diet. 30% of your diet should be lunch, 30% should be dinner, and 10% should be breakfast. Whatever is left you will snack in between. But what is important is to take food that is low in glycemic index. That means that will not increase your blood sugar levels suddenly. We do not want sugar spikes to be very high, because it not only affects mother but the baby as well. So once we start you on regular exercise and a nutritional diet, when do we do a repeat blood sugar level? So we repeat blood sugar after 2 weeks of diet and exercise. And what we want to achieve is a blood sugar after 2 hours of food should be less than 120 milligram. If your blood sugar is more than 120 milligram, we have to start some other therapy, whether it is medical treatment or whether it is insulin. So medical treatment which we give during pregnancy and which is found to be safe is called metformin. So metformin is a tablet that can be given morning, evening, and after that again we do blood sugar monitoring depending on how are your levels. So if your fasting blood sugar is less than 95 and your sugar after food, whether it is after breakfast, after lunch, or after dinner, if it exceeds more than 120 milligram, then we can also increase dose of this metformin. For some women, even insulin may be added. So highest dose of metformin that we can give daily is 2 grams per day. But if we are not able to achieve control due to that, then sometimes insulin has to be added, and we don't need to fear that we are taking insulin. It is good for both mother and baby, and we have found that such babies are healthier. So what is the target? Fasting less than 95, 1 hour 140, and 2 hours 120. So it should not exceed more than this. If we are not able to achieve these targets, then next thing is to take insulin. So once you start insulin, you need to also monitor glucose on your own. That is called self-monitoring of glucose with a glucometer, and you will be trained to do that by your endocrinologist. Another important thing is when you go into labor, then also that means labor pains start, we need to monitor your blood glucose levels, and ideal is between 70 to 120, because we don't want to lower too much and we don't want it to be high too much. After delivery, the next thing is, why are we fearful that mother should not develop diabetes during pregnancy? Because there are chances that she might develop diabetes just after birth. So first time when we have to recheck is within 6 weeks of delivery, because usually the pregnancy which has gestational diabetes, that is which has developed for first time during pregnancy, will be normal within few days to few weeks. Now, once the sugar normalizes after delivery, we need to check again at 6 months or maybe 6 weeks to recheck if this diabetes has persisted after delivery. Now, when she's planning for next pregnancy, before that we have to check, and every 1 to 3 years, depending on if you are overweight, if you have family history, or there is some other problem. Now, mother when develops diabetes, it is very important that we have to monitor the baby as well. So, in different societies and different countries, there are guidelines that keep varying, but the best time to start monitoring is from 32-week onwards, where your doctor will advise you to check for fetal movement count from 32 weeks or 34 weeks. In different countries, it is different, but overall, it is almost the same. So why is it important to monitor fetal movement? Because we know there are sometimes in remote cases in uncontrolled diabetes, there is risk of unexplained stillbirth, means baby can die in utero. This is the worst complication that can happen. So no pregnancy should go undetected that they can have diabetes, and no pregnancy should go unmonitored. So there are some tests that we do so that we are able to diagnose any problem in the baby before time and before it is too late. So one test is called non-stress test. This is NST. This is like a fetal heart monitoring strip that we get when a probe is applied to mother's abdomen and this monitoring is done. It is similar to monitoring that we do at the time of labor. Another thing we need to see is the amount of fluid around the baby. It can be too less, it can be too much. Especially in diabetic mothers, it is too much. So another thing, and third thing is the biophysical profile that we do on ultrasound. So how often should we do a sonography? So there are some mothers who have diabetes before pregnancy. For them, we need to see that what is their HbA1c, how has been their blood sugar control. If their blood sugar control was not good, we need to check for some abnormalities that the baby might develop during pregnancy, for which recommendation is to do level 2 like you do for any other pregnancy. Other than that, we will also do fetal echo to look for cardiac abnormalities and growth ultrasound scans to check if baby's weight is not more than the normal limit. Another important thing is to plan for delivery. So if mother has gestational diabetes, it is well under control, we can wait till full term, that is till your due date. But if sugar is not under control, if you are on insulin, if it is fluctuating, then we need to decide the mode of delivery and also the time of delivery. So there are some guidelines which all of us follow, is that we will do a planned or an elective cesarean if baby's weight is more than 4 kg. This is safety of for both mother and for baby, because a big baby, if we are trying to deliver normally, sometimes the shoulders might get stuck, the baby might not just come out, there may be trauma to the mother at the time of delivery, and so on. Another thing, sometimes we have to plan early delivery if glucose is not under control, if previous baby died in utero due to some maternal complication, or if mother is suffering from diabetic complications. So any mother whose baby's birth weight is more than 4 or more than 4.5 kg, we do counsel to go them to plan an elective cesarean delivery. Sometimes such women also go into labor. So such babies who are overweight, we need to explain them the risk of instrumental delivery, risk of vacuum delivery, and also trauma to mother and baby. So if you have been diagnosed with pregnancy diabetes and you go into labor, what is important is we will monitor labor pains, we will monitor sugars, we will monitor the baby's heartbeat at that time. Another thing is that when we are planning an elective delivery, that is elective cesarean section, we will stop your insulin on the same day as your delivery. We will monitor your sugar levels. And if sugar is high, then some insulin may be required. Now the baby is born, but a mother who the baby who is born of a diabetic mother will also need blood sugar monitoring, because if sugar goes down, there are problems which can be related to low blood sugar, not only in the brain, and it will lead to in uh, problems in cognitive development, visual problems, palsy, sometimes even autism or behavioral disorders. So it is very important to screen mothers at the right time, to screen women at the right time, and especially those women who have been diagnosed with polycystic ovaries, women who have previous babies who were overweight, women whose previous babies uh, had difficult delivery due to excess weight, and who have a family history of diabetes, women who are obese. So these are the risk factors that need to be identified prior to pregnancy so that we can make the delivery process smooth and it does not affect the future pregnancy outcome as well as of the newborns that are born, because they will also have higher risk of developing such complications which are related to diabetes. So over to you, Faisal.
Thank you, Dr. Nupur, for such an insightful session. Before we move into the Q&A session, we'll be initiating the poll. I request all participants to kindly share your feedback. While doing so, request all the participants to kindly post their questions in the chat window. Once again, I thank all our participants for joining our session today. We have received a lot of inquiry about the e-certificate offered by HRAI. You can claim your e-certificate by sharing your details, name, and session attended in an email to the email ID provided in the chat window. Please ensure you do this by the end of this month. We will email the e-certificates to you based on the details received. So, Dr. Nupur, we have received some of the questions from the registrations. I would just like to call it out. The first question is, can gestational diabetes cause complications during delivery? And what are the risks associated with gestational diabetes during pregnancy and delivery?
So this is, we all know that this is a non-communicable disease. This is a lifestyle disorder. Like we have polycystic ovaries, and that is how pregnancy itself is a diabetogenic state. For mother, in the long run, she is likely to develop diabetes in future. But during pregnancy, if sugar is uncontrolled, it will not affect too much for mother, but her future after first delivery, maybe during second delivery, she can again develop diabetes. In future, she can develop diabetes. If blood sugar control is not good during pregnancy, she might get infections. There can be urine infection. There can be non-healing ulcers, and it can affect the baby. So baby is affected in many ways. Another thing, at the time of delivery, it is very important to discuss the birth plan with your gynecologist for delivery, because if sugar is under control, sugar is not under control. What is the baby's birth weight? How is the baby doing? How are the fetal movements? Whether you have gone in labor or whether the baby weight is too much. So there are a lot of factors that will determine that what will be the best mode of delivery in a diabetic mother. It is not that women who have gestational diabetes, they are on insulin that they cannot deliver normally. We do a lot of normal deliveries also, but we need to be wise and vigilant that what is the safest for both mother as well as baby. So it has to be customized from person to person. There is no blanket treatment for one and all. It has to be customized depending on your sugar control. If it is an induced delivery, that means pains have not started on their own. We need to induce the delivery. Sometimes it might fail. There might not be response to the induction of labor. That is when we are giving pains. But at the same time, we need to be careful that fetal monitoring is not affected and you deliver in a place where there is facility for sugar monitoring. You have endocrinologist, you have ICU. There might be chances of trauma during delivery. Maybe the blood loss is more. So you should choose a multi-speciality hospital for this is a high-risk pregnancy.
Thank you, Dr. Nupur. Moving on to our next question, which is how does gestational diabetes affect the mother's health after pregnancy?
Yes, so it is the same question. It is going to affect, we need to monitor blood glucose for mother by the same test that is called GCT, which we do during pregnancy, where you will take 75-gram glucose and do blood sugar after 2 hours. It has to be repeated at 6 weeks and then 6 months and then every 1 to 3 years. And naturally, before you plan next pregnancy also, and during next pregnancy, your likelihood of developing this diabetes in pregnancy will also be higher as compared to others.
So the next question is, Dr. Nupur, can gestational diabetes lead to a higher risk of developing type 2 diabetes later in life?
Yes, definitely. So that is why we don't want mothers to develop diabetes in pregnancy. In India, especially, we are very prone to get diabetes. We are going to be the diabetic capital. If you know, I think everyone knows. So it is very important that we are able to prevent diabetes during pregnancy because it is also affecting the newborn's health. Even the child is likely to be more obese, likely to be overweight, likely to develop diabetes in future adulthood. So pregnancy diabetes, if we are able to control or if we are able to prevent by measures before conception, it will be a great help.
Thank you. Thank you, Dr. Nupur. The next question is, can gestational diabetes be prevented and what steps can be taken to reduce the risk? I think.
So yes, we need to see that our BMI is normal when we are planning for a baby. We are exercising well. What is our family history? What is our own blood sugar level? What is our HbA1c level? If we are fit and healthy prior, yes, it can be avoided. If we plan pregnancy at the right age, it can be avoided. The elderly, at an elderly age, you are more prone to have diabetes in pregnancy.
So one last question we'll take, that is, are there any dietary restrictions or recommendations for women with gestational diabetes during pregnancy?
Yes, you will be given a diabetic chart and your binge eating will stop, your cola will stop, sweets, potatoes, and lot of those products which are leading to sugar spikes will be restrained, and main eating will be healthy eating, more of protein in your diet and more of green veggies and fruits, but we need to calculate the total calorie intake. Maybe if you want to eat rice, we need to substitute and check that the next meal should not be too much of this. So balanced diet is important and you have to follow instructions given by your doctor.
Thank you. Thank you, Dr. Nupur, for answering all our questions so precisely and effectively. And thank you for this insightful and highly informative session. It has been a pleasure being with you today. I'm sure our participants had a lot to learn and take away from this session. Before we conclude today's session, we would also want to thank our event partners, Geisha, NASCOM COE, LinkedIn Local, Talgro, TLE, and WICCI for supporting these HRAI events. To know more about them, request you to kindly visit the links provided in the chat window. Thank you once again, dear speaker and our participants, for joining us today. Do join us for our next masterclass by Dr. Varun Agarwal, consultant urologist, oncologist, and robotic surgeon, Aditya Birla Memorial Hospital, on the topic uh, on 31st March 2023 at 3 p.m. That's it from our today's webinar. See you soon. Stay safe and bye for now. Thank you, Dr. Nupur.
Thank you.